If you have a question for Dr. Donna, please do leave it on my page and I will be happy to answer the question for you. All right, we are live here on YouTube and we are going to talk about schools today. So right now we're going to talk about schools. I am Dr. Donna White-Carey. This is Talking with Dr. Donna, and today we're going to do a subject about something that is really important. We have had a lot of information about schools. A lot of conversations have been happening about whether or not schools should reopen, and tonight we're going to talk about it. And I know that a lot of you have children who are getting ready to go back to school, and you're wondering if it's okay to send your kids back to school. And for me, even, I have 2 children, and I know that it is complicated and it is scary to think about whether or not we should send our kids back to school. Tonight, I wanted to give you some data. I want to give you the data, and I want to give you the information that you need so that you can make decisions for yourself. Should we go back to school? Should you allow your kids to go back to school? This is the data. We don't know a lot, but we do know some. And so what we do know, I'm going to present to you tonight. So the guest for Talking with Dr. Donna tonight is me, Dr. Donna. I'm going to give you some information. We're going to talk a little bit about some things that I hope will broaden your view of this situation and this discussion. And I'm also going to give you some things to think about and things that you can do as a community member, whether you have children or not, that will help you to be a part of this conversation, be a part of the solution, and be a part of helping our children, whether they return to school or not in the fall. So let me start by sharing my screen, and then we're going to go through the discussion. Okay, so hopefully you all can see my screen, and I'm going to go into a view that hopefully you all can see. Great. So coronavirus in children, we're going to look at it, we're going to talk about it. And I know a lot of you don't like lectures, you don't like hearing lectures. And so tonight I'm asking you to stretch yourself, because it is important that we lay the foundation so that you understand what it is that administrators are weighing and why this is not such an easy answer. I know so many of you are saying, well, the numbers are increasing, then it's a no-brainer. We should not go back to school. However, there are a lot of other considerations. So let's start with what we know. And let's start with just a very broad overview, again, of how coronavirus is transmitted. So we are attempting to prevent droplet transmission. The way we do that is covering our nose and our mouths, right, with some sort of mask or facial covering, that we then maintain about 6 feet of distance between each other, that you have some sort of eye protection. This is optimal. A lot of our children are not going to have the eye protection unless they wear glasses. Most of our children are not going to go to school with a face shield, but the teachers and the staff will more than likely have face shields, which is good for the staff. And then we're going to be encouraging lots of hand washing before touching mucous membranes. What are your mucous membranes? Your mouth, your nose, and your eyes. So before touching them, we want to make sure we have good hand washing. Let's talk a little bit about high risk exposure. So there's high risk exposures and there's low risk exposure. So the CDC defines high risk exposure as being exposed to someone who has tested positive for coronavirus and that you are in their presence for more than 15 minutes and that you are within 6 feet of them without wearing any sort of personal protective equipment. Okay, that's high risk. So if you don't have a mask on or don't have a face covering, you come into contact with someone who has tested positive for coronavirus, and you're in their presence for 5 minutes. Did you just have a high risk exposure? No, not according to the CDC. You did not, because you were not in their presence for more than 15 minutes. So we know the longer that you're in someone's presence, the less amount of PPE or personal protective equipment you're wearing, both of those things increase your risk of exposure, okay? So conversely, if you have on a face shield or face covering, if you are greater than 6 feet apart, and whether or not you know the person has coronavirus or not, you are not at a high risk exposure. You are decreasing your risk of exposure. And that is because of the trajectory of the droplets. And droplets you have just by regular speaking. If you put your hand in front of your mouth right now, you feel that moisture that's coming from your mouth, that's a droplet. Now imagine that droplet, imagine you are infected, you have that droplet, you cough or you sneeze, and that droplet spreads out. Again, less than 6 feet, no personal protective equipment on, and more than 15 minutes, you are increasing your exposure. This is why churches are we should not be coming back to church and preaching on each other and speaking to each other and singing, because again, more than 15 minutes of exposure, less than 6 feet apart, droplets flying. All right. Coronavirus, we know, is spread primarily through droplets. And in order for you to get infected, droplets have to land on you into your mucous membranes, your nose, your eyes, or your mouth. Again, I can't say this enough. This is why we want you to social distance. And this is why we're asking you to wear a face covering, okay? Let's talk a little bit now, going into the main crux of this conversation tonight. Some things we know for sure about coronavirus. Keep in mind, we have only been dealing with the coronavirus in this country for about 7 months. So that's not a lot of time to know everything about a disease. But there are some things that we've learned in these 7 months that we've had this virus in our community. Number one, we know for sure that infants and children can become infected with coronavirus. We also know that children get a range of symptoms that can go from very mild up to death. Thankfully, we have not had any childhood deaths. But we know, if we extrapolate what happens to adults, that death is probably possible. No children, sorry, that's a typo. No children have died from coronavirus. Children in Alameda County have a low rate of infection, but we also have a low rate of testing, right? We don't know if our kids are positive because we don't tend to test our kids like we are testing for adults. We know much less about children with coronavirus than we do even about adults with coronavirus. And that is because we have done so many more studies and so much more effort has been put into learning about the disease in adults. As usual, it happens with every single disease. We learn about the adults first, and then we trickle down to learning about children. So we don't know as much about children as we know about adults and the adult disease. And with proper protection, the risk of infection, that means face covering, hand hygiene, social distancing, we can decrease the rate of transmission of this virus by about 85%. All right, so those are some of the things that we know. Now, there are some things that we're pretty sure about, things that we suspect, but we can't say for certain. And some of that is that most children become infected with contact from an infected adult. That is pretty much our premise, that children can get infected, but the majority of the time, it's because of adults. And I'm going to give you some examples and show you some studies from other outside of the United States that will support this theory, and that's where we get it from. Most children have a cough or fever or respiratory symptoms, but the symptoms can be almost anything. Again, sore throats, headaches, diarrhea, We know that there is the disease in kids where we have multi-inflammatory system disease. So we know that that's a possibility as well. Lots of different things can happen with our children. And many children that we're finding by looking in other countries, they're also co-infected. So what that means is that at the same time that they're dealing with coronavirus, they also are dealing with something like influenza or some other respiratory condition. That makes it a lot more difficult, especially as we move into the fall and the winter. And we know that we are going to actually have influenza floating around as well as coronavirus. So I know that many of you may have seen this on the news. The American Academy of Pediatrics came out with a statement. The very first statement made many of us pediatricians and those who are members of American Academy of Pediatrics very upset by the statement that came from our president. And I think our president heard us and thankfully came out with a revised statement. And this statement was made jointly with not just the American Academy of Pediatrics that represents all of us pediatricians, but the American Federation of Teachers, the National Education Association, and the School Superintendents Association. So they all came out with a joint statement, which I actually really like, but I'm going to read it so that you just, for those of you who may not be able to see it as well, it says, returning to schools is important for the healthy development and well-being of children, but we must consider and pursue reopening in a way that is safe for all students, teachers, and staff. Science should drive decision-making on safely reopening schools. Public health agencies must make recommendations based on evidence, not politics. And I believe the very first statement was really based a lot on politics, but we're going to look at evidence, not politics. We should leave it to the health experts to tell us when it is time, this best time to open school buildings, and then listen to educators and administrators to shape how we do it. So this is a combination of science. This is a combination of working with our teachers, our administrators and staff, and our public health officials to come up with a plan of when it's the best time to return to school. I want to challenge you right now to broaden your view of going back to school. School is not just about education, as many of you may be aware, particularly if you are an educator. And so I wanted to put here some things for us to consider. And I want to thank my colleague, Rhea Boyd, for making sure that us pediatricians, that we think about what are some of the other implications of not returning to school. And I'm sharing these implications with you right now because I want you as a community member to think about something other than just the safety of the student. We also have to make sure that we think about the educational piece of the school and the feeding programs that are in the school. So what are some other things that we should think about? Think about the fact that schools feed about 35 million children a day. That's a lot of children across the country. And if there are no schools, then we need to make sure we have a way in which these children who depend on the school for feeding programs, for school programs, that we make sure that we continue to provide breakfast and lunch to these children. We also need to consider our special education students and our students who have IEPs or individualized education plans. How are we going to support these students? They may not be able to get on a Zoom and attend a classroom. They may not be able to sit still in front of the computer for 45 to 50 minutes. So how are we going to support those students? We need to make sure that those students are able to continue their education as well. We also need to consider healthcare. There's about 2,100, I believe, schools across the country that actually have a health clinic on site. And many of our children receive their health care from those health clinics. If the schools are closed, those health care clinics are also likely to be closed. Where are those children going to receive their health care? And then we need to think about internet. We know that the broadband access, internet access is not equal for all. So if we're going to go to school, if we're going to require distance learning, then we need to make sure that every household should have internet access. And because we are still dealing with the great digital divide in the number of our households, particularly in our households of children of color, whether or not they actually have a device, a computer, an iPad, to be able to get and log on to receive their learning. So this is something we need to take into consideration. We also need to think about home safety. So many of our children are not safe at home. There's domestic violence, there's physical abuse of their child, there's neglect. We want to think about that as we think about having our children in these unsafe environments. So again, these are just some other considerations so that you can recognize that school administrators are thinking of other things other than just simply educating our children. And now what are we going to do as a society to make sure that all of our children, not just the children of families who have the ability to afford computers and afford good internet access, but we know internet access has been glitching for everyone across this country. So what are we going to do about these things? And I want to broaden your view so that as you're having these discussions, you can recognize that there's something other than just simple education of our children. All right, so let me give you some data. Let me give you some of the case reports that are coming outside of the United States that really can help us guide what we're doing here in the United States. So we know that in some states that the fastest growing case rate is in the 6-year-olds to the 18 and the 19-year-olds. Now, we don't really have that type of data yet in California, but I can tell you that when I go to work now, I'm seeing younger and younger people with coronavirus that are symptomatic that I did not see 2 to 3 months ago. I'm talking 18 to 20, mid 20-year-olds who are now coming in infected and sick. So I will agree with this stat that we're probably starting to see a lot more of our younger and young adults become infected with this virus. So there's some studies that came out of China where many children, what they learned from this study were a couple of things. That many children were co-infected with not just coronavirus, but with another pathogen. And like I said before, we're going to probably see this, particularly as we move into the fall and winter, and our children have flu and other respiratory viruses that are more common in the fall and winter months. But they also found in this study something that was very, very interesting and something that will need to be continued in terms of studying. They found that the virus was shed in the child's poop for a month or more. Now that's really interesting, that this virus, even though the acute symptoms may be finished, the fact that you can still shed this virus in your poop for a month or more. Now we don't know if that poop is infectious, right? If you can touch the poop or if you're wiping the poop from a young child, can that viral shedding cause you to become ill with the disease? We don't know. Again, more to come, but these are just some things to keep in the back of our minds. There was also a study done in Switzerland, and they did 40 households, and they looked at those households that were infected, where people were testing positive with coronavirus, and then they said, well, let's look at the number of cases and households where the first person infected, which is what's called the index case, whether the first person was a child. Is it that the children are getting sick and then giving the virus to adults? Or is it that the adults are getting sick and giving the virus to children? So this study showed only in 40 households, so not a large study, but we do have some data from that. 40 households, only about 3 of the households did we see that the child was the first person in the household to actually become infected. But then what does that tell you? That tells you that the ability of a child to spread the disease to others is there, okay? Can't say exactly what those households looked like, whether they were small quarters or larger quarters, but the fact that the child was the first case in the household and then subsequent infections means that there is a possibility for children to spread the virus to adults. There was a study of a young boy in France. He was 9 years old. He was infected with coronavirus, and for some reason, we don't know, he was at 3 different schools. And he came into contact with about 80 different classmates. And from that presence with 3 different schools, 80 different classmates, no other children were infected. All right, so that's actually a positive for us to look at children to children transmission, right? In this one case, again, we don't have a lot of studies, but we do have this one case that this child came into contact with 80 classmates and no other classmates got infected with the virus. Okay, now let's move on to Australia. Australia, there was a study or a case study, 9 students, 9 staff happened to be infected. Between the 18 people, they came into contact with over 735 people. And that's a lot of people to come into contact with. And with that, only 1 student received and got infected from a child, and only 1 from staff. So really only 2 people got infected from about 735 people. And again, this is letting us know that we have the ability, considering our personal protective equipment, to potentially come and have our kids come back to school, but we've got to make good choices, and we have to determine how we can keep our children safe. So these are some of the studies that are out there, and this is some of the data that schools and administrators have been looking at to help determine whether we go back to school. I know many of you are talking about, well, if the kids go back to school, how are we going to screen them? How are we going to know if they're sick? So I'm just going to quickly talk about some options of screening. Most schools, if they return and are going to start needing temperature checks, right? So we are going to require that you take the temperature of the child when they come back to school. We know that there is lots of issues with our thermometers and not being as accurate as we want them to be. So one of the other things that have been placed on the table is to do a smell test. We know from a lot of our data and a lot of studies that the loss of smell and the loss of taste is one of the first things that you can identify to say that you might have coronavirus. Now, most of our kids are not really paying attention to whether or not they've lost their smell or whether or not they've lost their taste. So this is not something that you can self-report as you can with adults. So they are looking at doing something like a scratch and sniff, right? Where you scratch off and you put it up to them. What do you smell? Do you smell orange? Do you smell lemon? What do you smell? And that, if the child can then say, well, I don't smell anything, that means a higher suspicion. And then you move forward with screening that child a little bit closer. More to come on screening as we continue to look at whether or not our kids come back to school. But this is another option besides a temperature. I want to talk about children with asthma because so many parents have been asking questions about, well, my child has asthma. Can my child wear a mask all day or some sort of face covering? Is that going to place my child at a higher risk for having an asthma attack? Well, what most pulmonologists, that's the specialists, have said is that if your child has well-controlled asthma, then the use of a mask or a facial covering should not impact their breathing, and it should not cause them to have an asthma attack. Great, that's great news. But we know that most of our children do not have well-controlled asthma, unfortunately. That a lot of our children, particularly in communities of color, have poorly controlled or moderately controlled asthma. So the first thing that I'm going to recommend is that you attempt to get your child's asthma under control, that you take the medication and give the medication to your children as it has been prescribed by their doctors. I know that some of you say, well, my child doesn't have any symptoms. Well, that's great. That's the whole purpose of the medication, that they don't have symptoms. So use the medication, give it to your child as it is prescribed. If your child has ever had the use of an inhaler and has ever been told that they have asthma, then my recommendation is that you also have an inhaler at school, right? Because we don't know for certain if wearing a face covering is going to cause them to have any issues. So be prepared. Send an inhaler to school. For school systems, we've asked them to identify children who are at risk early. So we know which children in our schools have asthma and are at risk, increased risk for developing difficulty breathing. We want everyone to wear a mask and a face covering. We want to make sure that our staff is trained on how to identify a child who's having difficulty breathing and then what to do for those children. Do we have oxygen available at our schools? Is there an emergency plan available at our schools? These are all questions that school administrators and educators and parents should be asking each individual school district. All right, now let's talk about some of the considerations where we think about lunch programs. If we're back in school, what do we think about for lunch? What do we think about for physical education? So I'm going to go through some of these slides, and I want to thank my fellow colleague, Emily Frank, for these slides that I'm using. Outside and spaced out is ideal. In the classroom, you want to have greater than 6 feet. And you want to be able to have the food delivered. So if you're going to be in the cafeteria, you want to space the children out greater than 6 feet. If you're going to bring the lunches inside the classroom, again, you want your children to be spaced more than 6 feet apart. If you're using the cafeteria, you should have your kids wash their hands on the way in and on the way out, staggering times that the kids are coming into school and coming into the lunchroom. And keeping the kids together in small groups, that's the cohorts, right? Keeping the kids in 10 to 12 groups per, 10 to 12 kids per group. Let's talk about transportation. Lots of kids use buses or shuttles to get to and from school. What are we gonna do about our buses? What are we gonna do about those kids who rely on transportation other than families dropping them off? We want to make sure to think about doing symptom screenings before they get on the bus. And if possible, you want to have your kids assigned seats so you know where the kids are sitting. So again, if a child becomes infected, then you know exactly who sits around that child, again, to help with contact tracing. And it's good to have stable cohorts. So perhaps the same number of kids ride the bus or the shuttle at the same time every single day, again, to help with stabilizing the amount of contact that these kids are coming into contact with lots of other different kids. Wearing masks, of course, keeping them greater than 6 feet apart, and then sanitizing in between the pickups. So you have one set of groups in the bus, then when they get off, you wipe it down and make sure it is safe for the next group of kids. When we go back to school, let's think about physical education considerations. We really want to make sure that you are outside as much as possible, right? Which is going to be great in these early part of the fall. But when we go back to school in its winter time, it's going to be a little bit more difficult to do some of these things. But again, with planning and support, maybe our schools can actually do this. So we're going to maintain 15 to 20 feet away from students. Again, stable cohorts, minimize contact with the hands and the floors. Students should bring their own water bottles, sanitizing our equipment, and avoiding porous materials. If you're indoors, have about an hour spacing in between each cohort of children, all right? And avoiding our locker room use. What about the workers? What about the people who are working on campus? What are some of the things that we can do? We can make sure that, again, the group is as stable as possible, that they consider the workspaces, and that the students are in some sort of a hybrid model, perhaps. Let's think outside of the box. Let's be creative. We're going to need creativity during this time. Ideally, you want to have one set, each student have their own materials. Now, this is tough, right? Because in school, the kids share crayons, they share markers, they share all sorts of supplies. But perhaps as we move back into the possibility of returning to school, instead of having a bucket full of crayons or markers, perhaps each student is going to have their own little mini bucket that they're going to need to use during the school system. We want to avoid any sharing of materials that can get under your nails. So Play-Doh, probably out, right? I love Play-Doh, but probably not the best thing to use during this time. And we want to make sure we teach our kids how to practice good hand washing. All right, I know a lot of you are probably thinking, oh my gosh, that is a lot to do. Are we going to be able to do it? Can we safely do it? Well, we do have a success story, believe it or not. We do have from data from the YMCA of how we can have our kids come together and not have an overwhelming number of infections. So the YMCA, they have sites across the country, and they studied their sites, including a site that was in New York City in March or April. So kind of in the height of when New York was really the hot epicenter of the disease. They looked at about 40,000 kids that they had cohorted together in their YMCAs across the country. And most of them were ages 1 to 14-year-olds. Surprisingly, during this time, there was less than 1% of staff members that were affected. That was about 1 staff member per site that got infected. And thankfully, no children actually got infected during this time. So can we do it? Absolutely. But in order for us to do it and to do it well, we're going to need some help. And that is where each and every one of you watching this comes into play. We all have a part, whether you have a child or you don't have a child. There is something that you can do. So you can be an advocate, and particularly you can advocate for broadband internet access for every single household for free. We need to do this in order to make sure that we can enjoy education experience in every single household, not just the household's means, but for every household. You can also talk to your local school. Talk to them about their plan. Talk to the district. Talk to the administrators. Determine what their plan is and see where you might be able to offer resources or maybe to be able to offer help. Maybe you can say, I'll adopt a classroom and I'll buy markers or pencils for every child in this classroom. Or there is, maybe you have some land. Maybe you have a business. Maybe there's something that you can do to allow children to have more outdoor space or opportunities to spread out and enjoy physical education. Maybe you have an empty building that you're not using that you can donate to the local school system to say, hey, we can put some things inside this open building so that kids can run around. There's lots of things that you can do as a community member to help out the school districts as they're attempting to make their plans. You can also help. There might be a family right there in your own backyard, right next door, who needs some help. Maybe you have an extra iPad that you're not using or a computer that you're not using that you can donate to a family member or to a friend to make sure that the child can have access to online learning. And then you can contact your state, your local, your county leaders to demand that our schools have additional financial support so that they can do the things that they need to do to make sure our kids are safe and healthy if they return to school. Maybe they need more stools. Maybe they need more teachers. Maybe they need more volunteers, and you might be willing to volunteer. There are some things that you can do to help. So we have a lot more to come, a lot more to learn about this disease, a lot to consider and think about in terms of the transmission. Like I stated, we can say for certain that the majority of the infections are going to probably come from adult to adult transmission between staff and teachers. That children, particularly in elementary school, do not seem to transmit the disease to each other as easily as it is from adult to adult. We also know that we can, though, transmit the disease from child to adult, but we don't know what that rate is, and we don't know how much it will impact our students. So there's a lot more that we need to learn. There's a study that's getting ready that has already started, actually. Dr. Fauci is starting a study and looking at the percentage of children infected with coronavirus to really help determine what is the incidence or what is the true number of kids that are actually being infected with coronavirus. And then what does it look like in our children? What are some of the impacts and symptoms that we may not know about for our children. So there's a lot more to come with our children. I want to talk a little bit, because there is a difference that we're seeing in some of the studies between elementary school students, middle school students, and high school students. If you look at the data, you can see that elementary school students, not so much this child-to-child transition tends to be very, very low. And in middle schools, it's a little bit higher in terms of transmitting kids the disease from one student to another student. And then in high school, that rate becomes also just a smidget higher than it was in middle school. So we know as the older the child is, the more likely that the child is to transmit the disease to each other versus to the adult, or the adult down to the child. So there's a couple of outbreaks that we saw across the world. In France, there was an outbreak in the high school that there were about, I think 100 kids or more that were infected in the high school in France. And then we also saw a couple of outbreaks in Israel of kids in high school where, again, over 100 students were infected. And I want you to remember the outbreaks of the elementary school student, right? The 9-year-old who came into contact with about 80 students and no other child got infected. But here we are in high school, where the rate of infection from child to child tends to be higher. So we really don't know the details about these outbreaks. We don't know, were the students wearing masks? Were they doing them, having them sit 6 feet apart from each other? What was the inside? Were they inside or were they outside? We really don't have a lot of details about these case studies, but we can say that there definitely seems to be a difference in the rate of transmission of coronavirus from student to student as the student gets older. Safer in the elementary school than it is in middle school, safer in middle school than it is in high school. More to come. I know that we have a lot more questions than we have of answers, but what I was hoping to do and wanting to do tonight is to just lay a foundation for you so that you can understand that this is a complicated issue, not as easy as black and white. We are not going to be able to use a one-size-fits-all approach to returning to school. Not every school and in every school district is going to be able to do this in the same way. So we have to be able to allow our schools to be flexible and to consider things that are different for each school system. And each school system is probably going to do something a little different. It's probably not going to be the best to say nobody return back to school. Why? Because again, some of our children receive food from school. A lot of our children who have special needs, who are special educated or have individualized education plans, what are we going to do and how are we going to support those students? So a one-size-fits-all approach is not going to be how we should look at returning to school. A hybrid approach, considering perhaps staggering our school times, staggering our start times, staggering who's on campus in the elementary school, middle schools, and high schools. We do know that transmission from child to child is possible, right? Some of the data that I gave you tonight shows that it's possible. So that means that we then have to make sure that if our kids do return to school, that they have to adhere to the things that we know that help to decrease the risk of transmission. That means your child is going to have to wear a mask at school all day. Get them ready, because that's going to help decrease the risk of transmission. We know that our students need to be 6 feet or more apart. What are our classrooms going to look like? Is every school district able to have that type of separation with the number of students in their school? Thinking about teachers and staff. I know that I had a meeting with my kids' school a few nights ago, and I suggested that there is a stable cohort of teachers, that the teachers do not move for more than 2 weeks at a time, so that the cohort can be as stable as possible. The same number of kids, a small number of kids, somewhere between 10 and 12 kids seems to be the going number of what's safe, and that the teachers move right? So if you have a Spanish teacher, an art teacher, a music teacher, that perhaps they do Spanish for 2 weeks, and then while the other students are doing music or doing art, and then after 2 weeks, that teacher then moves to a different cohort. But it has to be a stable set of cohort, and it should not be day to day or hour to hour that our teachers and our cohorts should change. The question of whether or not we return to school really is also going to depend on what does the rate of infection look like in our community at this right now. Right now, it doesn't look great. Right now, we have cases that are rising. We have more and more cases and more people becoming infected. That is definitely going to impact the decision on whether or not we return to school. If for some reason our cases dramatically decline between now and when school session needs to start in the next couple of weeks, we probably need to make these decisions. Then perhaps we go back to school. But it really will depend on what our rates look like. And that means that depends on you and your family members. Are you wearing a mask or a facial cover every single time you go out of the house? Are you attempting to social distance? Are you making sure you're washing your hands multiple times? We all are in this together. The fact that our cases are rising, these are not the kids that are causing, the elementary school kids that are causing our rates to rise. It's the young adults and our adults. So your children, your grandchildren going out there, you've got to have these conversations to let them know that what they're doing is impacting the learning and the education of our children. We know that middle and high school students are going to have to be considered and treated a little bit differently than we think about our elementary school. So that's another nuance for our school districts and our administrators and teachers. What do they do in middle school and high school to keep the kids safe and then also keep our teachers and our staff safe? So more considerations. And we know that the highest risk of infection for the teachers and the staff are really going to come from the teachers and the staff. So that means we have to make sure that our teachers and our staff are protected, that they have the personal protective equipment that they need in order to be safe. Lots of things to think about, lots of things to discuss, lots of things to consider, not just whether or not we keep our kids safe. So thank you so much for listening. I know it's a lot of information and a lot more questions than we have of answers. But what I'm hopeful is that you learned something tonight that you can share with your family, that you can share with your school district and administrators and teachers, so that we can figure out a way in which we continue our learning for our children, that they can continue to learn and be educated in an environment that is safe, in an environment that is healthy, and an environment that supports them. I'm Dr. Donna. This is Talking with Dr. Donna. I hope you learned something tonight, and hopefully I see you next week. You always have an appointment with Dr. Donna every Thursday, so come on in and let's talk. Take care. We'll see you next time. If you have a question for Dr. Donna, please do leave it on my page and I will be happy to answer the question for you.